Good evening, everyone. Welcome to the Main Agreement 101 webinar. My name is Jane Narayan. I am the current president-elect of the NP Council. I am a nurse practitioner who practices in primary care and the current clinical director at Access Primary Care Clinic in Cloverdale. Alongside with me this evening, we have Angela Wignall, who is the Chief Executive Officer of NNPBC. Angela is a registered nurse and has been with NNPBC for the last 3 years. We also have Zach Tishian, who is the former executive director of the Nursing Policy Secretariat and Provincial Chief Nursing Officer of BC. Zach has been retained by NNPBC to support learning around the NP Main Agreement. Zach is a nurse practitioner with a focused practice in primary care and addictions, living and working in Nelson, BC. We'll start off this evening by acknowledging that NNPBC serves and supports nurses working across the full breadth of what is today known as British Columbia, home to 203 First Nations, Métis communities, and Inuit. As an organization committed to anti-racism with a profession dedicated to social and justice and equity, we stand in these relationships with humility and with respect. Personally, I am joining from Vancouver, which is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. Our agenda for this evening includes a history overview, the current negotiating and advocacy processes, NNPBC structures, barriers, Main Agreement 101, and finally ending off with questions. First of all, we'll start with a bit of history. A professional association is an entity that seeks to further advance the profession it represents and the interests of the individuals within that profession. The first association for nurse practitioners in British Columbia was BC NPA, which was created in 2006. While BC NPA existed, most of the NPs worked in the health authority, including BC NPA past presidents. All advocacy at that time was related to NP advocacy within health authorities. There was never a mechanism or legal framework to allow for formal regular communications or negotiations for NPs at that time. Past presidents did take opportunities to connect with government during this time, although all matters of contract changes for health authority nurse practitioners were conducted through communications between HEABC, the Ministry of Health, and VPs of HR or medicine. There was never an NP that was formally at the table. However, past presidents took these opportunities for advocacy work. For instance, when the Doctors of BC announced family physicians retiring and a primary care crisis, this was an opportunity to allow the vocalization that NPs are willing and able to provide this care. At that time, there was a white paper that was created and given to government to influence NP integration into primary care. And with advocacy and stakeholder engagement, these service contracts for primary care were created. Relatively around the same time, when service contracts were implemented, BC NPA worked with ARMBC and amalgamated, and together created NNPBC, representing all nursing designations across BC. The amalgamation allowed for a stronger provincial nursing voice and for operational support. Currently, NNPBC is comprised of a board of directors, which includes 2 members from each designation and representation from CNOs, education, and students. This is led by the CEO and operations team. This slide represents the structure that specifically is related to NPs within NNPBC. All of the council work is volunteer, and the NP Council serves 2 purposes. The main function of the NP Council is advocacy and leadership, where the council, with member engagement, identifies, discusses, and brings forward policy and practice issues that impact our designation. Another function includes the NP negotiating team, which consists of 4 members, 2 senior advisors, the president or president-elect, and our legal team. Once service contracts were developed, an engagement framework between the NP negotiating team, HEABC, and the ministry was developed in order to allow for regular connections and negotiations to service contracts. The engagement framework was the first formal document to establish the relationship between the Ministry of Health and NP Council. This is possible because service contracts are not embedded within the health authority structure and policies and do not apply to service contracts. It is important to note that although the NP Council negotiating team had a formal engagement framework with the ministry on service contracts, their advocacy has always included all nurse practitioners, regardless of model of care. At the present time, the NP or engagement framework has expanded to acknowledge in writing that although the NP negotiating team does not have formal authority to negotiate for health authority nurse practitioners, all of our efforts relate to all designations. The ministry and HABC acknowledge the NP Council negotiating team's interest in health authority advocacy. Thus, the NP engagement framework states that these conversations can occur, though it is known that changes within HA-NP contracts are still officially sit between HABC, the ministry and VPs of HR. Next, I will invite Angela to review the operational structure of NNPBC pertaining to NPs and all other nursing designations.
Thank you so much, Jane. It's my pleasure to be here, joining from the unceded homelands of the Lekwungen-speaking peoples, the Songhees and Esquimalt First Nations in what is today known as Victoria. NNPBC is the first unified association for nurses in Canada, and we're leading the way in British Columbia in that regard. We do a wide range of activities that support advocacy and leadership for all nursing designations, and in particular, add to the incredible leadership work of the NP Council. In particular, NNPBC has core functions as the professional association, and those functions include policy and advocacy, including government relations, opportunities for practice education and research, as well as a wide range of supporting business functions that allow a professional association to exist. And I'll share a little bit more about those core functions in the next slide. We've also been home to the Nurse Practitioner Provincial Initiatives and Programs, or the NPPIP, which is a primary care program that provides practice supports, provincial and regional leadership supports, and reimbursement programs for nurse practitioners providing care in primary care settings. Those of you who are familiar with the NPPIP, and particularly the provincial and regional leadership team, know the value of this program that has been running at NNPBC for many years now. Next slide, please, Jane. Thank you. So those core functions of a professional association are organized for us around specific streams of work. Our streams of work include member services and events for nurses of all designations, but in particular, you might intersect with member services around things like webinars, our clinical corners. You might also intersect with our perks program or your support for commercial general liability insurance and other insurance products that we offer, including your connection to your professional liability protection. And events that we offer all nurses across the province, including fun activities like our hockey nights, as well as provincial recognition events like our awards program. Primary care programs at NNPBC originally began with NPPIP, but we're also now home to a second primary care program, the Nursing Initiatives for Primary Care, that provides support and community to RNs and LPNs employed in primary care through the Provincial Nurse in Practice program. We're proud to be working in alliance with the Ministry of Health's Office of Indigenous Health and Reconciliation to create space, convene opportunities for healing, and grow services for Indigenous nurses in particular. And that work is led by the incredible Dion Thavarge here at NNPBC. As well, under our Indigenous nursing umbrella, we're growing a program called the Anti-Racism Praxis Support Program, which aims to help nurses of all designations engage in the praxis of meeting your professional standard around cultural safety, cultural humility, and Indigenous-specific anti-racism. Our practice education and research teams support a wide range of activities, including professional practice consultation, engagement at a multitude of provincial practice tables and advocacy tables, the provision of continuing professional development and learning opportunities, and engagement with research to advance the discipline and profession of nursing through knowledge generation and knowledge translation. Absolutely critical to the core of all of our work is policy and advocacy, and that includes liaising with multiple ministries within the Government of British Columbia, as well as partners across the healthcare system. You may see, for example, recent developments specific to nurse practitioners on our website, including our advocacy for specific naming of nurse practitioner work within the Premier's mandate letter to the Minister of Health, as well as recent advocacy around the NP insured services under the interpretation letter from our federal government that was recently released. And of course, all of our work would not be possible without our business operations teams, including communications, finance, marketing, our website, and our administrative teams who keep the lights on at NNPBC and make sure we can have conversations like the one that we're having today. Thanks, Jane. I'll turn it back over to you.
Thank you, Angela. We wanted to quickly highlight that we hear our NP membership. We see all of your emails sent in through the NP concerns form. We want to acknowledge that we typically are not able to reach out to every single individual personally, although the concerns over the years have been taken and organized into the themes that we've seen here. And these include complexity and panel size, salary remuneration, locum and parental leave coverage, overhead, flexible funding models, shift differentials, WCB and ICBC compensation, and integration of technology, including AI. We also want to highlight HA-specific priorities, and these include after-hours shift premium, rural and remote retention funding, on-call funding, workforce stability, as well as provincial approach to NP leadership. How do we ensure that every table is aware of the barriers pertaining to nurse practitioner practice across the models of care? And how do we allow for unity between all nurse practitioners? How do we come to understand a provincial strategy for nurse practitioners? And this is done through the engagement. We currently sit at multiple tables, and these include, but are not limited to, the following: the NP Council negotiating team, ministry, and HEABC engage through our engagement framework. We also have regular every 2-week meetings with the ministry to discuss soft conversations which are essential to conversations that lead to further engagement. We meet with our HA leadership as well as PIP leadership. We connect directly to members through our town halls and open council meetings, which occur at our conference. And we have our NP concerns form. The final is the provincial collaborative table, which is an advisory table inclusive of leads from the Health Authority, PIP leads, the NP negotiating team, and the ministry. And at this table, a systems gap analysis was created, speaking to all barriers we see across the province, which from our perspective highlights the need for flexible funding models that would allow nurse practitioners to deliver the kind of care that is needed within the geographical areas and contexts that they practice in. Further to this, a provincial strategic recommendations document has been created. And we see that this strategy moving forward would be through an NP main agreement. And this would be housed within a division of NNPBC dedicated to this work. We wanted to also separate the difference between the service contract engagement versus the NP main agreement. The NP Council negotiating team engages with the Ministry of Health and HEABC on a regular cycle to advance the service contract agreements. This will start in April of 2025 with an expected service agreement announcement later in that year. This is not the same process as the NP main agreement. And the NP main agreement would, if nurse practitioners choose to continue forward with this, begin in 2025 and 2028 and is separate from the service contract conversations. Call on Zach to discuss the main agreement for nurse practitioners in the province.
All right, thanks so much, Jane. So I'm Zach Matiashin, and I'm pleased to explain a little bit more about what main agreements are and what it might be for nurse practitioners. Next slide. So why are we talking about this now? So NPs have been practicing in BC for nearly 20 years now. Some of the first classes graduated 18, 19 years ago. And we know that there's really only been two fundamental compensation mechanisms. For a long time, it was only NPs as employed within health authorities. And then more recently in 2019, with the primary care strategy, a new compensation model was created by way of the primary care service contract. And we know during most of this time, NPs have not had a formal negotiating status. We have not been unionized. We've not sort of had a mechanism to negotiate our the details of our supports and compensation. The one caveat being, of course, NNPBC has developed an engagement framework to facilitate these discussions on PCN contract compensation, as Jane just explained. And during this 20 years, there's really been a variable strategy on NP implementation. Those of us who are long enough of tooth remember the first 200 positions that were funded at the start. And then when they were filled, it wasn't clear of where the direction of NPs were going to be, and some people were graduating and not and finding a practice situation, having to go back to be RNs. And then there was the NP4BC initiative in 2010 to 12, which had its own issues, and then of course the PCN strategy in the last 5 years, which we're all familiar with. I would say, in spite of this, really the province, and I'll give a shout out to health authorities, operations and leadership have done really incredible and innovative work in optimizing and implementation. For lack of clear direction or even a clear funding source, they have very innovatively and creatively created positions for NPs to practice where British Columbians need them, be it primary care or tertiary or long-term care or specialty sites. And the other issue we've had provincially is there's really no central, comprehensive, and clear direction on how NPs fit within the system, but also how some of the other players that have come on the scene. I'll look at physician assistants and associate physicians. So that's our landscape. Next slide. We also know that the profession is growing at an ever quickening pace. We went from 45 seats when the whole thing started to 165 now, and really that substantial uptick has just been in the last 8 years or so, a nearly tripling of seats from 2017. So really, we're training NPs at a breakneck speed. We're at about 1,200-ish registered right now. Some work we did in the ministry a couple of years ago was projecting where would we be by 2028, and we saw a doubling. We were at about 1,000 at the time by 2028, and I would say that number is even conservative if we consider the OSCE has been eliminated and some of the interprovincial and international migration of NPs has been streamlined. So really, we may be underestimating the number of NPs that we'll see in BC in the next few years. I use the term too big to fail. I think we're there. In the start, I think many of us noted that we were small of number. We really wanted to prove ourselves, the value proposition to the system. If we got too noisy or demanding, perhaps the system would decide that nurse practitioners aren't worth it. And so we did a lot around relationship building, proving our value proposition, evaluating our work. And I think we've done that successfully. And the system really needs us. We're everywhere in most sectors of tertiary and primary care. So really, we're too important to ignore. And so I think now is the time for us to sort of push and take the next step in our sophistication as a profession. So as we'll explore here, a well-staffed and resourced approach to improving our relationship between the profession and the government of BC will allow us to sit at the table in a more organized, sophisticated way than we have been able to before. looking at, say, the physicians, for example. They have a dominant position. They are the architects of their future, and they write their narrative. And so I would like to see us get to that point as well. Next slide. So what's a main agreement? So you may have heard this term, you may have heard the term master agreement. There is a bit of a change in the vernacular happening where certain terms are being looked at critically. So I think a main agreement is what we're going to see these types of agreements called going forward. And so what is it? It's a formal comprehensive agreement between a health profession and, in our case, the government of BC. Really, the point is to represent mutual interests and define certain things like compensation and payment structures, all the myriad supports that a healthcare professional might need by way of practice support or CPD, depending on the compensation model, details of benefits or pension plans, and then other aspects. How does the profession engage with the Ministry of Health or government by way of joint committees and how mutual priorities might be set and dispute resolution. These agreements tend to follow the same cycle as collective agreements in BC. Really, everybody negotiates the same way now. Everybody, be it a main master agreement or a collective agreement, will negotiate for a 3-year term. There'll be labor peace, and then it happens all over again. So the next cycle is actually happening right now, where these groups are negotiating their next 3 years. Next slide. So what's the downside of this? Well, we could look at cycle as a negative. It could preclude opportunities to address emerging issues that are of interest and priority for the MP profession. But as I note that, because once these things are signed, they're sort of locked in, and you don't open them again for 3 years. That said, there are exceptions. Now, if there is a mutual interest between a profession and government to expand a compensation model or change things, it can happen as long as both parties agree. I look to the LFP model, which was something that was hammered out for primary care physicians in between the 2022 and the 2025 negotiating cycle. So it can happen. What else is a con? Well, it does change the nature of the relationship between the profession and the Ministry of Health and Government. Some of the meetings and committees that exist need to be stood down during that time so that either side doesn't prejudice themselves by sharing too much information. It can also have the potential to cause friction in relationships with other healthcare professions. This is something that could be true without a main agreement, but it's something that we should be aware of. A main issue for nurse practitioners is how employed MPs would be rolled into a main agreement. Really, there's a system where employed MPs and health authorities are sort of managed, and they would need to be divested from that in order to be properly represented by a main agreement. And lastly, it's expensive. It takes a long time to figure out, and it's time consuming. So these are things that need to be considered as we consider taking these next steps to prepare for a main agreement for NPs. Next slide. So what could be in a main agreement? Well, really, it's a pretty open page on that. Really, anything that both sides feel are a mutually identified need. If we're looking for ideas, we could look at the physician master agreement. Certainly, there's provisions for fee-for-service. That may or may not be a future state for professions, but it's in there for them. Certainly service contracts, something we're familiar with. Sessional contracts, we're certainly aware of. Physicians have, but we don't. Alternative payment plan models for sort of unique rural areas. There's salaried employed physicians, so we can consider them sort of the equivalent to health authority employed NPs, but these are actually excluded from the CRP, so physician master agreement can actually represent those employed physicians. And there's also provisions for other things like rural practice incentives, MOCAP, which is the medical on-call program, and all these sorts of things that I think NPs look at and operational leaders look at and say, you know what, I think this would be a benefit if NPs could access this in order to optimize how NPs are integrated in the system. So for NPs, what would it be? I think it would be some mishmash of those things I've just said, but really it's about us looking what does the system need, what do NPs, how do they want to work and practice, and where is the overlap there, and that would be what we would pursue. Next slide. So how do we start? So we really need willingness on the side of both parties, and I think if we show that the NP profession is willing and interested, then government would need to understand the value proposition. Why would they want to start this whole cumbersome process? And so we would really want to prove that really there is a value added to have NPs comprehensively articulated with a myriad of different tools in a toolbox to be able to flexibly permit and facilitate their practice in a variety of settings. Government may need to feel that adequate pressure is necessary from various spheres, and government hates negative press, so they want to at least be aware of any blowback that may occur from other healthcare professional organizations, such as the physicians. So these are things that we would work to mitigate. They would also want to have the support of health authority leadership, which is something I think I'm not out of hand of saying that this is something that I think health authority leaders are aware of and see the benefit if NPs had a main agreement. And lastly, government would want to see a professional organization that is legally structured to be a negotiating body, is adequately resourced to have the people and the resources that it needs, negotiators, data analysts, government relations, NP engagement facilities, and so forth, to really permit this work to happen. Next slide. How long would it take? Really, if we look at other jurisdictions, it does seem to be about the 1 to 3 years from initiation to final agreement. So this is something that we could consider commencing this year in 2025. If realistically we're looking at the next negotiation cycle to commence in 2028, a 3-year term ending in 2031, this is the time where we would want to begin this. And what would we do? We would want to assess and consider the right organizational structure within NNPBC that would need to house and push this work along through negotiation, policy work, engagement. We would need to do a ton of engagement in a way we've never done before, where the NP profession is thoroughly engaged, where we understand what NPs want and what they would envision a future state main agreement. We would want to speak with operational leaders to understand what the system needs and so forth. So these are some of the pieces of work that would be in front of us in the next couple of years, building up to 2028. Next slide. And so who pays for this? And this is something that the question comes up certainly in my previous role in government. Is there a secret pot of money, or when a novice or new profession wants to take those first steps to organize, is there a little nugget of money that can be handed out? Unfortunately, no, it doesn't exist. So it's up to us. So these are a consideration and an exploration of budgeting that we have yet to do. But really, if we look at some of the other healthcare professions, we were all nurses. We remember paying 2% of our gross straight time pay. For an average RN, that's sort of pushing $2,000. Midwives pay quite a bit, 2.9% of their MSP billing. So typically, that's really almost $3,000 to $4,000 per year. Doctors used to pay $1,600 a year, and it's increased to $2,300. So these are all entities that we know do this sort of work of advocacy, membership engagement, and formal negotiation with government. So this does give us kind of a clue as to what sort of numbers we're looking at to uh, have members pay. Next slide. So the elephant in the room, I'm sure, is what about health authority employed NPs? I won't go into an exhaustive explanation of what the CRP is, other than to say that there is a structure that sort of defines how health authority MPs are compensated, how decisions are made to adjust that scale. It's really looked at in a more global way against other um, usually non-clinical staff within a health authority. Uh, and this is part of the problem that I think that has been known to health authority employed MPs for a while, that this system kind of works well for management and leadership, but it doesn't really understand clinicians as well. And perhaps it doesn't make sense for NPs to be represented and governed by this reference plan. And I think it's fair and accurate to say these adjustments that happen for health authority employed MPs really occur without a clear mechanism for nurse practitioner engagement and advocacy. It is sort of a conversation that happens behind closed doors within health authority leadership, between HABC and so forth. There's really no way for NPs to sort of be the architect or the negotiator for their future details there. Next slide. There has been some work to move NPs away from this reference plan. Those who have been in practice for at least a few years will remember a time where you had to complete a performance-based review every year that really felt kind of arcane for a clinician. It was developed for leadership, so finally that was done away with in a movement from a 13-step grid to a 3-step grid. And again, I know that there was some growing pains with that. Many of us came from a union background, but really physicians aren't remunerated in a stepwise approach for experience. It's kind of a flat rate. You know what you're doing and you get paid the same way. There are some barriers that exist due to the CRP still that Jay did suggest that we're hearing from NPs, certainly employed NPs, to receive evening and night differentials in some facilities like urgent care settings and other tertiary sites. And so these are things that could be addressed and advocated for in these intervening years between now and 2028 to further disentangle NPs from the CRP and to permit access to some of these retention techniques that I think would be useful for NPs vis-a-vis these differentials. And I think it's important to note that this isn't a switch that we can or should turn off tomorrow for NPs from this system within health authorities. That system does a lot of things that are useful, like articulation of benefits and a pension plan and so forth. So that switch should not be turned off until there is something to replace it. And I'll say that should probably be a main agreement, which articulates how employed NPs at health authority sites are supported through benefits and pensions. Next slide. Just a quick note about the provincial initiatives and programs shared cost agreement. This is just an example of what could be in a main agreement. These are some mutually identified programs and supports, particularly the sort of genesis of this was the PCN contracted NPs in providing some programs for practice support and other services for these contract NPs. It has since been expanded to include other incentive supports that are available to other NPs as well, and some notable things like actually paying divisions of family practice to uh, sort of support NPs who are members and so forth. So this sort of, I call it like a proto main agreement that has begun to fill some of the gaps in services and supports that physicians receive through their master agreement. Next slide. So, back to my first slide, why now? Well, I think now is the time. It's 2025, it's been nearly 20 years. Timing really is everything. I think the stars are aligning, and this is our moment. We're hearing support from a variety of spheres on this. Leadership at health authorities are interested in this. I think there may be a moment, even from ministry and government, that really our articulation of the value proposition of us organizing nurse practitioner compensation and supports within something like a main agreement would be of mutual benefit. And really having our own robust and resourced team to engage with ministry and come with our own solutions that we've thought up, that we've had smart people with PhDs or whatever, however we build our team to articulate the future of nurse practitioners instead of just sort of, you know, uh, letting it happen. However, ministry decides NP should be implemented. I think there's huge value in that for us to co-create our future. So if we act now, we can build a structure to interface in a modern and sophisticated way and write our own narrative. Next slide. So what comes next? So really we're doing part of that now. We're continuing our membership engagement with presentations like this. We'll be going to all of the health authority department meetings. We have already met with the PCN contractor community of practice. Really, we want to understand NP's concerns about this. We want to explain as much as we have about the potential here. We will be engaging with government and ministry as well to understand this. We will be doing work around forecasting a work plan and a business plan for this. How much will this cost, really? I think you'll want to know that, what we would be budgeting for to accomplish this work and what that would mean for you on a per year basis for a membership fee. I've sort of made a rough guesstimation of 1,200, 1,500 based on other professions, but maybe that's wrong. Maybe that's too high. Maybe it's off. So we will be transparent in providing further analysis for you. We will want to go to the profession to seek by way of survey or vote or however we call it, but we want to know if there is a majority interest in this from the profession. We'll probably seek that in the next few months. And from that, you're not bound to it if you vote yes, but it will sort of give us an idea if we have broad support here so we can approach government and take these steps. NNPBC will be completing an internal review around what organizational changes are needed internally to build sort of a business division to do this work. And I've just sort of put government relations and advocacy. It may be that not a lot of advocacy is needed with government and Ministry of Health. Maybe they will agree this is a good thing to do and let's get started. Or we may need to nudge it, a bit more along the way using tried and true methods like government relations, meeting with the health minister, meeting with the opposition, public engagement, media, and so forth, if we need to. Next slide. All right, thanks, Jane. That's all I had to share on that.
Thank you, Zach. So this concludes our presentation in regards to the components of the main agreement, the benefits. We welcome any questions to myself and Suki.